Nu ieșisem în timp ce...
You hear us?
Perfect, mulțumesc frumos.
Hello, Gregory. We are in direct. We can see you. Hello.
The next case?
Hmm?
Do you want me to show you the next case?
Yes, just give me
We
1
can't
second.
hear you.
Pierre.
Nu l-auzim pe ea. Da, începem. Da, am văzut. Hello, we can hear you, but we can see you, but we can't
Are you happy
hear
with
you.
this marking?
Your microphone.
Just so you know where it is, sort of, it's just, hold on, I'll mark the other one as well.
Well, lubricant. And we have the APC for the snare to mark. Soft coagulation for marking. We have the cautery device, but we have the cautery to hook up to power. Irby or
No, we can
is
do
it?
We
Is
can
it?
hear you.
Okay.
Everything is fine.
Okay, good. All right. So if we give you the endoscopic image, patient is left lateral. There we go. We'll just have a look. We have carbon dioxide, CO2.
May you give the endoscopic view, please? Yes, great.
Okay, we're just going to wash the stomach first.
1 second.
Clean it as much as we can. We're going to do transmural suturing, so we expect a puncture through to the serosal side, and this can lead to a little bit of translocation of bacteria and also small amounts of carbon dioxide in the peritoneal cavity. So we're not surprised if we do a CT scan to see a little bit of capnoperitoneum.
So you have a carbon dioxide device?
Yes. Mandatory. It's mandatory for this procedure, yes.
Yes.
Okay. So the principle is, we're going to have a look here now. We're good. I'll suck it out. So we want to imbricate. We want to pull the anterior wall from anterior to posterior. We have to pull this towards the lesser curve. So we have along the anterior wall, we will make some marks at the level of the incisura. Here, we're going to go along the anterior wall, make marks up along the anterior wall here. And then along the posterior wall, we'll make some marks. And we go to try to perform the gastroplasty within 1 centimeter, if possible, of the gastroesophageal junction. Right now, if we make note, the gastroesophageal junction's at 36, 37 centimeters. So we want to go probably to about 38 to about here. So we want to pull this in as much as we can up in this area. So if you keep in mind this view, then we'll compare it to the view at the end of the procedure. Okay. So first we'll do the marks with the tip of the snare. So we have the cautery. I'm not sure of the settings. Soft coag is good, yeah? Okay. So we use the snare tip as the cheapest way to do it. And I always, when I'm using cautery for any procedure, whether it's ESD or polypectomy or marking, I always test it away from the area that I'm going to work. So we're going to basically put the snare tip out, just a little bit, too much, a little back, okay, right, just, okay, hold it there. We'll put a mark just pre-pyloric, it's very safe area, very thick muscle. You can do very little damage in this area if you have to, so let's see. And we have glucagon or, no, we need more power, not enough power. Do we have soft coag, we can turn up the power. So this is the test till I don't know this device, so I have to wait till they set the power for me. So we,
The glucagon for lowering the peristaltic of the
yes,
endo.
yeah, that's right, that's right. Maybe the snare can come back just a bit. Just a bit. There, good, perfect, perfect. So now we're just waiting to get the patient grounded so we can use the electrocautery. Okay, okay, now I think we're there. We're going to test it again. Let's just test. More, we need more power. That's not enough. Let's see. Yeah, that should do. So we just have to have a general guideline. This is not like ESD where you have to be very, very precise. And we're going to look here to see where we're going to start. Probably start about here. So we'll go from the anterior wall up here. And I'm just going to go along here. Just to give myself a little bit of a guideline, you have to pull back to see roughly how much you're going to pull in from the anterior wall. And I'll come back a bit, there we go. So we're just giving ourselves a guide as to where we're going to be. We'll suck back now, a little bit of, when we distend the stomach, it's a little bit harder, we'll suck back. Again, along the anterior wall here. Oop, out a little, let's maybe clean this off. We have to clean it off. So you can see we're going to create a line here, and the other line will be along the posterior wall. Yeah. So now we clean a little bit.
Why do you begin with the anterior wall? Does it matter?
Pardon me?
Why do you begin with the anterior wall? Does it matter?
Well, there are different strategies with the stitch pattern, but as a rule, it's easier to pull the anterior wall down towards the posterior wall. So we're going to start there, and then we come down. But it's, I think it's just the way it evolved. The first procedures were done proximal to distal, and it was found to be much easier to go distal to proximal. Everybody does that now. Okay, out a little bit. Okay, back. That's good. Okay, let's continue to mark. We'll suck back a little bit. Okay, there we go. Okay.
So the marking from posterior to anterior to posterior is not very important, but beginning with
Anterior. Yeah. Distal. Start distal.
distal is mandatory.
Yes. I would say, yeah. Now there are different techniques, of course. The pose technique, which is primary obesity surgery endoluminal, this is with the USGI medical device or Endomina device. That's where they do just plications. Those plications are done more towards the fundus. It's a little different than this technique. Okay, let's see where we are. We're coming up a little higher. Okay, and maybe here. Okay, I think that's at the GE junction and over to here. We might be able to get one more. We'll see. We'll put it here. That's about as high as we can go. We still have a capacity of about 150 is what we want in the fundus anyway. And now we'll go back. We'll mark the posterior line. If you want to go to another room, you can go and come back, and I'll bring you back every time we do something different. But I'll get this done now. Okay, no problem. Needle out. Do you want me to snare out a bit back? That's good, thank you. Okay, my assistant is very good. I see him on camera a lot. He's doing a very great job. Thank you. Okay.
I would ask you,
Oh, is it out a bit? There. Yeah.
you make biopsies in order to see whether there is some atrophy of the gastric wall or something?
Yes, I mean, the contraindication, obviously, we treat Helicobacter. The patient, no ulceration. If there's a large hernia, we don't like to do if it's a very large hernia. A small hernia is not bad.
Because afterward you'll close this part of the stomach and you'll not be able to see.
Yes, good point.
We are ready
Yeah.
to start. We are ready to start in room number 1. So we are going to switch there.
Okay.
Just 1 second.
Dr. Deprez, you are live.
Okay, we just start here. Checking my scope first. So I'm using a GF UCT 180 from Olympus. Well, I like to use balloon mainly to have a better image for you, but this is not necessary for therapeutic. And I'm working with Radu.
Yep. Hello.
Yeah, okay, let's try this way. Okay, lights. So as you understood, this is a patient with toxic alcoholic pancreatitis with past history of another cyst that was treated by surgery, which is...
Putem să luăm mâna din față,
Yes.
să o ducem de-a lungul corpului. Mâna
which
asta.
is in our center never done anymore. I think there is no much indication for that, except maybe in some cases where you have a doubt on the nature of a lesion. Okay.
Am voie să o iau eu în jos? Just making some space for Pierre here, opening him up the
Yeah,
area.
that's okay. Yeah, that's
So-
fine. First point is to suck out the gastric contents. Always better if you do something that's transgastric, is to avoid any risk of complication. So if you have a lot of fluid and bile, better to take it out. So if things fail, there is minimal contamination.
Carbon dioxide for inflation.
Yeah. And then I usually have a look to the pancreas before, just to check the ducts. So let's go to the bulb. We are in the bulb now. My technique is to go directly to the second duodenum,
Putem să scădem puțin
then
lumina
to
în sală?
place myself in the short position, and then you should move to the EUS image. Getting slightly, where is the depth? Okay. Right, so there you get to, I don't need the endoscopic image anymore, just focus on
Sorry.
the pancreatic head. You see the pancreatic head here. You see the bile duct. Can you show them?
Yes, yep.
The bile duct. And I'm just turning my scope. The patient should not move, please. Really bad. Anti-clockwise, okay, so there you go to the hilum. And you see you get to the hilum here. So for the previous patient you can already have an idea if there is a tumor by this position. If you want to get another view then from the hilum, you can go from the stomach and then go for the liver and then go from the liver to the hilum. So this is now the clockwise turn. No, please. The patient should really not move if it's possible. And then clockwise I go back to the ampulla, and you see the ampulla here. Can you show the ampulla?
Yeah, hold on.
Ampulla here.
Ah, sorry.
Okay.
Yeah, got it. Yeah.
You see, and the pancreatic duct will get here. Bile duct is here, and it's turning to the liver like this. And yes, okay. So you see the ampulla very clearly.
There you go. Okay.
I don't need all the background behind. Okay. You see the ampulla very nicely. Okay, yeah. And then we go to the, you see there is, you still see the ventral enlarge of the pancreas, which is dark. And the pancreatic duct, which is maybe slightly large, but I think it's still below about 3 millimeter, I guess.
2.2.
In 2.2, there is no sign of obstruction, no stone. There are some hyperechoic areas in the pancreas, And then I'm going to follow the pancreatic duct.
So not many criteria for chronic pancreatitis.
No, here we
yeah?
have a stone. We have a stone here. Okay, so that's a stone. And I'm losing my pancreatic duct here somewhere. The patient is really moving a lot inside. Can you some Buscopan or things like that? Because when I puncture, I will really need very calm.
So is this calcification in the pancreatic parenchyma?
Yes, because the duct is just below. Yes,
Yeah.
where you point.
So this is the calcification, if you want, in the pancreatic parenchyma.
yeah.
So that would be one of the minor criteria for a chronic pancreatitis.
Well, it's a
It's a major, and then,
criteria. Yes, and you see,
even if you have just one, is one enough to be major?
well, if you have only one, you have always to be sure it's not vascular, because you can have patients with vascular calcifications, and then of course you. No, the duct is here, please.
Yeah, no, I was on the calcification. Yeah.
Okay. Yeah, take the flow off. No.
Take it off. Okay.
I really don't understand the comments. So I'm really trying to follow the pancreatic duct to see if there is any reason for this huge cyst. And we lose it here, so I guess it's then opening in the cyst, but I don't see any clear connection. Yeah, it's somewhere there, but we lose it.
Now,
We
if
lose
you would
it
have a
here.
connection, would you consider to drain this cyst transpapillary rather than transgastric, or not
No,
necessarily?
I usually only drain the head, the cyst locations in the head of the pancreas through the papilla. For the rest, I think it's better to drain them by transgastric or transduodenal. Transgastric is usually preferred. Okay, and there we have a huge collection.
This is really huge.
Okay,
If you
That's very
sort of just
nice.
let me freeze this for a second.
yeah,
So you get
yeah. This is not the biggest.
you
but
get
it's
9 centimeters by also 9 by 9 centimeters, and the second thing I think was
oh, it's even bigger than that.
it's even than that. Yeah, it's even
Yeah, it's more
So-
than 10 centimeter. Yes.
yeah. I'm zoomed at the maximum also.
Okay.
It's kind of the maximum dimension.
So you have to look at the dimension, and then you have to look at two different things. One is the presence of necrotic debris inside, because then it's more like a one. And then you may consider other ways of drainage than plastic stenting. Okay, that's fine. So that's one point. We don't see any debris here. Sorry, I lost it. Oops. Okay, there. Then you have to position yourself. Sorry, Radu, but I'm
That's
going
okay.
to
I
take
can
some
move out. I'll
my-
move
my
out of
best
your way.
place. So sometimes you have to move your scope to be in a better position for drainage. Okay, so this is you should really have your scope that's free. Okay, you see it's free and it's well positioned, and you are in front of the screen, so you are in very good position here. The next thing you have to check is reason for bleeding inside, and so I usually use the flow to go all over the wall to be sure there is no pseudo aneurysm. So in most of these cases we perform CT before to be sure there is no risk for bleeding. But you can of course check this with the yeah, usually it's better than to have a small window and then to go with the window to different parts, because otherwise you have a too high background. But it takes time. But I think there is no sign of, we don't see any vessel in the wall. Of course you have to be sure it's not a tumor, but we have here a typical history of, okay, so typical history of acute pancreatitis, which is I think quite good. Okay, so next step is to decide where to puncture. So there are 2 or 3 things to watch then, to pay attention. The first thing is of course not to have any intervenient vessel. So we had a vessel earlier on there, so you should not puncture in this area because there was a vessel.
The puncture
Yeah.
direction usually comes out from here, and it usually
Yes.
goes this way.
Yeah, so you should
So this is what
you should
I usually
avoid
like
this.
to do.
You
That
sh-
keep the cursor
yeah.
there and then
Yeah.
watch
and then
how
of course the space should be narrow between the gastric lumen and the collection, and you see we have less than 5 millimeters, so that's quite good.
We should switch to room number 2 because Professor Haber has started the procedure.
Okay, perfect. Yeah, no problem.
You're happy with this?
Come back, we'll reload down here. Let's see if it reloads. Yeah, I think it's going to reload.
Professor Haber, you are.
Oh, okay. So let me explain what we've done. We've just begun to stitch. So the pattern is to start with the anterior wall. So you're looking at our first stitch at the top. Then we get the greater curve, and then we get the posterior wall. So those are the first 3 stitches that we do. Then we go back up, and we're going to get the interior wall again. 3 more stitches, grabs with that, with the 1 suture. Then we release, and we pull that, we cinch that part together. Then we take another suture, and we repeat. So at this point, we're reloaded, we have to go back up. We're going to suck. We have to get up here. This is the second section here. And we're just using a lot of suction to try to bring the stomach to us. And also it reduces the risk of having your gas go into the peritoneal cavity. So now we have the helical retractor, and you see it's a tissue retractor. You'll see in a moment. Open it. You see this screw, basically, tissue screw. So we'll go in, up here.
Like a corkscrew.
Like a corkscrew, exactly. And we're going to get the tissue. Yep. Sucking, sucking, sucking. Okay, now 3 times.
Okay, done.
Now we're going to pull this in. I don't like this. I'm going to get on the other side. Open, release it. I like the other side better up here. It's going to be, yeah, release. Go over here. Let's see if I can, there. I want this part here. Not yet, not yet. I'm sucking, sucking, sucking. Just want to get that anterior wall as much as I can. We're sucking here. You can't see it, but okay, now go. 1, 2, 3. And now we'll suck the wall of the stomach. We're going to pull this up towards us. Okay, we're pulling the tissue in.
More than 3 times because you don't want to get too far in the peritoneum.
Right. But it's pretty thick. This end of the stomach is quite thick. But of course, the more proximal we become, the more danger of a perforation. So now we release. We're going to release the tissue. We go back and forth. There we go. Okay, so now we'd let the suture go. So there we go. And now we're going to come back and reload put the suture back on the needle driver. So the needle tip is inside the bottom right. There's the needle driver. It's not connecting. This device is a little fussy. There we go. And we can reload now and take it off now. Now we'll go back to the middle. Okay, in here. And we're going to just suck, suck, suck. Helical retractor out. Grab the tissue here. Just a second, I want to get it about here. Here. We don't want to leave too many gaps. We want it in the middle. Well, again, we're sucking now. We have to wait for our suction to take effect. As I can't pull it, I don't want to pull too hard because you can pull it out of the tissue. So we're trying to suck and pull at the same time. We want to get transmural stitch, so we keep sucking. There we go. Now we have it. Now I have to pull the needle off of the needle driver, coming off, open the needle, release the tissue. Okay. Come back, okay. And now we have to reload. There we go. So there is our needle here. We'll go down. We're going to reload, then we'll cinch, and then we'll take that out of the way. Pull this back a little bit more. Let's see if it catches it. It's going to catch it. It's good. Okay, we reload the needle on top. And now our final grab will be sort of down here along our posterior wall, which is where the mark is here. You can see how the marks help us at this point. Okay, now we'll go out with the helical retractor, the tissue retractor. Just a sec, I'm sucking. Okay, we can go ahead and grab the tissue. Okay, we'll pull it up, suck. We'll push the scope in a bit, turn, rotate right, just to get as much as we can. There we go. Okay, now we put the needle through, pull the needle tip off, needle driver back, release the tissue. Okay, that's it. So the first set of sutures has been done. So we're now going to release the suture. Has a little T tag. So if you watch the end here at the end of the scope, you'll see the tag. I'm going to release it. It's being released. There, it just got released, and it's went down onto the posterior wall here. I'll see if I can, it's in here. Let's see if I can show it to you. Maybe not. And the little T tag is there. So it's there, and now we have to cinch up here. So what we do is, it's released, we come out with this. Now, we need the cinch device. If you could hold the scope, just like that. Yeah, that's it. So basically, the camera can show you this. Just hold this with one hand. If the camera gives you close-up, come very close. Are you getting a close-up view? You see this, there's a cinch here that goes over the suture. So we're going to thread the suture through the cinch. So we do that this way. It's okay. So we go through like this, just a sec. Hold it like this myself. And then we pull down this way to pull the suture through. And then it follows the suture. Hold that, and the cinch will go down. Okay, let's put this over on this side so you can do that. You have that. I've got this, there's no problem. Okay, we hold the thread. We'll go down now with the cinch. Just a sec. It's tied up. Okay, we have it. It's okay. Yeah, hold the thread there. That's it. Thank you. So I can hold the thread. Okay, I've got it. So now we'll go down with the cinch. Oops, we're caught on top. You see the thread here on the endoscopic view is caught, so I got to get it off. Now it's out of the way. So the cinch is going to go exactly where the first puncture of the tissue was. The cinch will go along the anterior wall. If we pull a little bit before the cinch goes down, we're just giving ourselves, you can see how you pull the folds together. Okay, so we don't want it too tight because there's a lot of motility in the stomach, and if it's too tight, the motility is enough to pull the stitches out. So you want it just tight enough. What is just tight enough? It's experience. So we'll go down with the cinch. You'll see here in a minute. Okay. So the cinch is coming. There's the cinch coming out. So that's the inside of the cinch. The outside of the cinch is that metal at the bottom. So the suture is caught between the end piece, which goes inside the bottom piece. So we're going to pull this up. And I'm going to just put a little bit of pressure on this. So I'm tightening it up a bit. I'm pushing forward and pulling in the folds of the stomach. Back and forth. We're pulling in a bit, back and forth. Okay, I think it's good enough to cinch now. So to cinch, the way we do it, hold it, just let me explain. If you push forward with the blue, turn it on its side, let the white piece come out. No, you have to push forward with the blue. Like that, and turn it on its side, and the white piece falls out. Now you take 2 hands, close it as hard as you can. Let that go closed. 2 hands all the way. Keep going. You got it. Okay, so it's a little bit difficult to get the cinch, but you can see the white cinch is there, buried in the tissue right there. So that is the first. Now we have to go back and we repeat this up along the stomach wall. Okay, so we have to reload. We'll take this out, we'll reload. Okay, you can take that out for the moment, clean off the tip. So now we're going to repeat this. I mean, again, you don't have to stay. You can stay if you like, but we're going to just repeat this along the wall of the stomach. And in between, try to deflate the stomach as much as we can. There we go. Okay. So here, I'll help you reload. You okay? You put this in water first? Oh, you did already. It's very good. If you hold the scope, Florian, just hold there. And let's just show the audience how we do this. Where's the... huh? Oh, you've got it here.
Yes.
Sorry. Okay. So this is how we load the suture on. I don't know if you can go in close. You see the needle tip is here. I'm not sure if the camera sees this. Close-up view. This will grab the suture. So now the needle is caught, and now we're all set. We wet this first, and it usually comes off. This is 2O polypropylene suture. And you take that off, take the white off. Okay, that's fine. And we'll go back down and we'll load this onto the needle driver. Just a sec. We don't want to get too tangled here. That's good, thank you. There we go. A little bit of lubricant always on the rubber, always helps. Now we go back down. Endoscopically, we'll watch the loading. There we go, it's coming out at the end. The suture's there, we push forward just to make it loose.
Can you hear us?
Yes. Yes. Yes? I don't hear the audience. We're on this.
It looks like a pretty complicated procedure.
You know, it looks more complicated than it is, honestly. It's quite simple, and it's not precise, it's not exact. But as long as we can pull the imbricator, pull the greater curve of the stomach in and line it up, it works. But
Do you feel that the endoscopic instruments need refinement?
yeah, good point. It's a very good point. I mean, yes, the stitching device is a little complicated, and this could be simplified. I mean, the Endomina is a simpler device, but does not grab as much tissue. That's the problem. You can't get right through the transmural grabs that we want. I've got to get up, I'm just trying to get up to the right area now for grabbing the tissue. We want to get up here by these marks. Okay, so now just suck, suck, suck. This is the anterior wall, needle out. Okay, there we go. Grab the tissue. What's the question?
How do you insert it? Orally, very orally.
Oh, well, we close the needle driver, which is a curved needle, which is behind the scope. So then it's in line with the scope, and we just go, we don't use an overtube. We used to use an overtube, but now we go without the overtube. The problem with the overtube, okay, we got it there, is that it leaks air. It's harder to inflate the stomach.
Okay, so we are going to switch to room number 1.
Yes. Okay.
Okay, we're on.
Okay.
Yeah. Hello, welcome back again.
So I was telling that you should check for vascularization, the distance for puncture, and then you should be away from the cardia. So I really pushed my scope as much as I could along the collection to be in the mid part of the stomach. And then I inserted a needle, 19 gauge needle, expect from Boston here. And you see the needle. Can you show the?
Yeah, I'll show the needle.
Yes. The needle is going to come out here, so you first have to adapt the length of the shaft of the needle. You have to fix it on the scope, and then I'm going to make the blocker here at 4 centimeter, and then you should see the needle moving you have to use the full torque of the full bend of the scope and the full elevator lifting also to have the most perpendicular of the less tangential approach to the lesion. And sometimes in very old suture cysts, this might be complicated. Okay, so you see the needle now that comes out, and I will do a quick movement. I will block this at 3. Okay, so you should not hesitate. Once you are ready, because otherwise you may just glide over the capsule of the cyst.
The thing that this moved here is not bothering you.
No,
No?
no,
Okay.
no. Then you aspirate the fluid, and you see it's clear fluid. There is no blood, so that's a good point. We take some out
little
just
bit.
for
Little bit.
culture, and then
Guide
the guide wire, yes, just for culture. And if you have a doubt, you can, of course, use do some biochemistry on this. Okay. The guide wire now.
Do you usually have the risk of gliding when you puncture? If you go like very...
It happens. It may happen, yes. It may happen, and especially in old ones, old suture cysts, sometimes you have a calcified wall also. Okay, so you see that's what we're discussing, fluoroscopy or no fluoroscopy. You could do this without fluoroscopy, but of course you are safer with fluoroscopy. So I'm just pushing my wire, and I see my wire is advancing, and I'm sure now it did a turn. You see it coming out around the cyst. Can you just take this out
Yes,
and
sorry.
show the wire?
So it turned out here
Yes.
somewhere, yeah.
So I think that's
Yeah.
very that's for me that's okay.
Yeah, after the 450th you can do it without fluoro, probably not
Yeah,
before.
Yeah, but of course the exchanges of devices are better done, safer done with fluoroscopy. So let's have a look on fluoroscopy. Can you have the fluoroscopic image? And you see that the cyst is the suture cyst is quite big, and you see we saw the distal tip of the wire coming close to the entrance. So next step then is to take the needle out and to prepare the cyst gastrostome. So I'm going to take this out.
Perfect, super.
Okay. Unlocking the needle, and then we are going to advance it together. Okay. So you should not push too much. Usually on the EUS image you see the wire if it's moving, so you have to keep the EUS view on the wire all along the changes, and stop. We check fluoroscopy, and you see there is no change in the wire neither. Okay, we're taking this out. Of course you need a good assistant. We have to feel each other what we are doing, and this is nicely done. Needle is out. We have to don't forget to do this, put the valve again, and we usually put it on the cystotome, so we are sure we don't forget it. You put it on the right position on the cystotome. We have a check on fluoroscopy. And then usually my technique, but there are many different techniques, is to use a 10 French cystotome to bring it into the pseudocysts with endocut. We don't need the other device, huh? Okay, take
Just
out. Take
hold on,
out.
hold on. You may need it when you come across the other.
No. We don't
Okay.
need it. We don't need it. Oh, I wish. This should be right, but in some scopes, if the elevator is not functioning very well, you may have problems to get the thick part of the 10 French cystotome out of it. And is the valve there somewhere? Yes, you have it in your hand. Okay, yeah. Perfect. Okay. And then we advance this. Usually it's free in the cystotome, so you don't need fluoroscopy for this step. And then you get slowly to the tip of the scope. It's getting stiffer then. Okay. And you see on the EUS image, you see that the tip of the cystotome is getting there. So we connect it now. And then we'll use... Please?
Which are the settings that you use?
Endocut I or endocut Q, it doesn't matter too much. What should be ready is the next wire, so that once we are inside, we will put the second wire along the first one. Okay? You can already open
the second
yes.
wire.
So I'm going to push my cystotome here with endocut. There is no current. I don't. We should hear something. Should it work? Yes? Is it okay? Effect 1 is okay. Effect 1 is okay. Okay, let's try again. We should see something on the EOS image. We should see bubbles or think something happened there. I don't
it's
see
not
anything.
happening, no.
I'm sorry, but it's.
Mouse van das in de message.
This is not working.
Okay, we switch to room number 2.
Okay, try again.
Come back.
Try again.
Okay, let's try again.
Okay, go there, grab the stitch, pull back.
Professor Haber, we are with you.
Okay, just release the tissue. All right, this is the second suture. We have anterior greater curve, posterior, back to anterior, two greater curve. We have one or two more, and then we're going to cinch the second suture. So we're still working on our second suture here. We do a total of about 6. So, usually takes about an hour and 20 minutes for the procedure. We're reloading the needle driver here. You can see the first is here. We're going to come in, and there's our last one. We're going to suck back. We're going to get some tissue here. Right in here. Okay. Grab the tissue. Okay, we'll pull in, coming in, grab it, take the needle off the needle driver, release the needle, release the tissue. Okay, and then we'll probably do our last, we have to reload, and then we'll, on our reloading, we've learned that we have to turn the needle a certain way for it to work properly. You see it's missing there. So I have to try to just see if I can get this to change a little bit its direction.
So we switch to room
There.
number 1.
Yep, there we go.
Okay, so this was successful. We just changed the settings to endocut eye, which is the normal setting, of course, for this.
Yeah.
And we are inside, as you see on the EOS image, you see that the cystotome is inside. Okay, and we're inserting a second wire. Okay, you can push a wire. Yes, continue, yeah. Continue. You see the second wire that's doing the turn again. Yes. The same position. Okay, so now we have the two wires inside. So you keep the two wires together, Christian. And I'm going to put this away, and you prepare the stand, please. First stand. Okay. You push.
Alla
7 centimeter.
The chapter now.
Okay, so we get this out. Okay, so this is out. You can
Yes,
push. You can push. I follow your movements.
Do you find the multi-gateway technique useful?
I never did it. I did it maybe once in a necrosectomy in a one, but usually it's not necessary. The main problem here might be infection, so that you have to repeat drainage or change a stand or putting 3 stands. But this again mainly happens with necrotic collections and not with pure pseudocysts. Of course, the stands can migrate also. So these are reasons for infection. The migration rate is the same for plastic stands, for lamps. You can have migration with lamps also. So this one is the long one first, the 7 centimeter.
Yes, the
It's
7 centimeter. That's a 7
with
centimeter.
this Zeeman Cook stand, you have a taper tip that should be put in front, of course. And I usually put a black marker on the stand, on the distal pigtail part. to shift then to the endoscopic view once I've seen the stent is okay. So now the major risk is putting the stent inside the cyst. If you put the stent inside the cyst, of course you are getting trouble. Then the most easy way to get rid of the trouble is to put the lamps and go through the lamps to grasp the stent, of course. Okay, so now we have to do this safely. So to avoid the risk of migration, the best then is to, when you have a large collection like this, the best is to place a very long stent. A very long stent, yes, so that you have more security, more safety when placing the stent inside. When I do this, I always keep my elevator closed so that I can feel the stent, and I also have a look to the to the EUS view, because you will see the stent also getting there. Okay, so I think we see the stent here, so the stent is getting inside. Perfect. Perfect. Now you have to pull the wire.
Hold on just 1 second.
Okay, pull the wire so that the tip of the wire is inside the pigtail. Remove the wire, okay. Okay, more. Perfect. So that's fine, we have the stent inside. So now I'm going to move to the endoscopic view. And as you know, the endoscopic view is slightly too far away, so I'm going to use the big wheel to get away from the wall. Okay, getting away from the wall. And you see, when you have blood, of course, this might be complicated because you will have a lot of fluid, and suction is not very efficient. I will just suck a little bit to give you a better view. You have to abandon the EUS view at this stage, and then I'm going to pull my scope to avoid putting the stent inside. So once, Christian, I ask you to pull the wire, you pull it. You don't ask yourself, should I do it, should I not do it? You just do it, okay? I should see the markers at some point. Once I see the marker, you see the marker here. Okay, so this is a marker Radu did for me. The pencil was not very clear, but so you see the marker there. So I'm going to...
It's not a nice handwriting, but it works.
It works. So I'm going to really torque my scope anti-clockwise here. Okay, release please. Okay, perfect. And then I go back to the hole I made. I go back with my EUS scope. Okay, we check position of the other wire, and then we go for the second stent placement. Usually with 7 French you should not dilate, but in some cases you may need dilation. So at this step, if you want to be very safe and if you have a lot of money, you can dilate. And it's quite safe to dilate since you have a stent in place. You should not push the stent, of course, when you push the balloon, the dilator, but I usually don't need it. And for that you need to be very close to the entrance because it's a pigtail. So a pigtail, of course, can bend, and then you can be out of the appropriate direction. Okay. So this is mainly then endoscopic view. You can also shift to the for the EUS view, but I think we put air in the stomach, so it's more complicated to have a good EUS view at this stage. Okay, so there we come. So we stay very close to the wall, and we try to advance it slowly. You should not go too fast. If you go slowly, it will advance. And of course, you should pull slowly also. Okay, so I felt the passage of the wall, so that's fine. Okay, so I'm pushing, you pulling. Okay, so check fluoroscopy since we have it. You can pull more. And you see my second marker is here. You can pull more, please, 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 so that the, okay, so the second loop of the pigtail is done. And now I'm going to pull my scope to be away of the entrance. Okay, and again, when I will tell you, Christian, to pull out, you don't hesitate to do it, because sometimes you are pushed away with the scope. Okay, go. Perfect. So I agree it's a little bit longer than a lamb's placement, but with this technique you can do this in less than 10 minutes. So the advantage of the 5 minutes, I think, is not worth the expense of a lamb's for a pseudocyst. But of course, this is different for necrosectomy for once. And I think for pseudocysts like this, you need, especially with this patient, she had already another pseudocyst earlier on, you need a long-term drainage. And I would leave these stents for a while, and I would check either by EUS, MRI or CT if there is a disconnected tail due to a previous pancreatitis. And if there is a disconnected tail, I would leave the stent in place for years. So I have patients with stents in place for more than 5 years and no recurrence of the cyst. If you remove them too early, at 3 months, there are studies showing that there is a high risk of recurrence of the collection. Now I empty the stomach a little bit for the anesthesiologist so that she is not inhaling the pancreatic fluid, but this is done.
Can you show us the endoscopic ultrasound image?
Very nice demonstration.
Yes. Thank you.
Thank you. This is the room number 2.
I never do that, because by doing this, you touch.
Professor Haber,
Yes.
you are live again. Thank you.
We are now on our third suture. The last one we took about, I'd say 8 bites. We just started our third suture, which we'll try to show you. Yeah, you released. Let me come back. I'll try to give you a view. You can see we're now creating this little bit of a tunnel here, and now we're working our way back up. So we have to reload our needle. We have a little bit of problem with the device, but I think it's going to work. The reloading of the needle can be a challenge. Oh, we have to see where the needle driver is. There, we're reloading. There we can see better here. Missing. So we're going to try here. The alignment is a little bit off with this this device. Let's just see here if we tell you a different direction. I'm going to take it over here. Maybe take some tension there. Maybe I think this might get it. This is usually not a problem, but sometimes if the manufacturing, if it's off by a millimeter, it can make it more difficult. Okay, now there's our posterior line is there. So we're going to take, I think this one, we'll take one more in between, then we'll go to the posterior line. So we'll go here. There we go. Needle out. Okay. Go ahead, grab it. I'm sucking, sucking, sucking. We have the tissue. We'll pull it in. Okay. Release. And now we'll go to the posterior wall. Okay. Okay. Pulling the suture in a bit. Let's see if we can reload in here. Just made it. Good. And now this is our posterior wall line. We'll go in here. And we'll grab the tissue here. Go ahead. And pull this up. There we go. Now we have to take the needle off of the needle driver, release the needle, release the tissue, reload, and go back and do it again. I'm sorry, it's somewhat boring, but it's going to work. Okay, so you can see how we've got the line of sutures from anterior to posterior here lined up. Now we have to repeat beside that, and then we're going to cinch it closed. We have a limitation of 6 sutures in this case. So I'm going to reload it here. I think, no. Let's see if we can just move there, maybe there. It looks a little more medial. There we go. Okay, now we have to go back up top. And we're going to suck, suck, suck. We'll pull our suture back here just a little bit so it's not in the way. There we go. And our mark is up here somewhere. There's our mark. So we'll try to get the tissue up here. Go ahead, needle out. Go ahead, turn. Okay, we'll pull this in. Okay.
My impression is that the sleeve is larger than the surgical one. Is it true?
You mean the tunnel that you create is larger?
Yes.
It is a little larger, but I think you'll see it'll close down more when we finish, but it is a little larger.
Release?
A release. Okay. Reload. Okay. Actually, it's better if we reload on the other side. It's crossing over here, so I'm going to reload on the other side. So the way we do that is go down. Hopefully this will grab it, pull it off. Okay, let's see if we can reload on the other side. There, let's try here. Okay. There we go. Maybe it's going to be all right. There we go. Okay. Now we're going to go back up in here. Let's pull this out of the way. It's still, sorry, it's crossing over. I've got to get this over on this side. The crossover is a little bit difficult. Let's just see here.
Right.
Let's go to the right side if we can.
Да.
It's harder to get over to the right side. Let's see if this works. Yep, caught the other suture. Ha! It caught the other suture. Oh my God. Okay, this can happen. Let's just. Okay. I'll just come around here. There. Okay, now I think that crossover is from before, so I'm going to leave that. And it won't make it impossible. No. There we go. Okay. And now we have to cross back over here. We have that. We have to go in the middle. Okay. We'll get more tissue in here. We have to suck out. Grab the tissue. 1, 2, 3. Yep. Oops. Do it again.
Okay.
And we'll suck, suck. Oops, not holding. Let's try another spot. Okay, try here. Sometimes the tissue, the helical retractor, gets tissue stuck. It doesn't grab as well. We're going to suck. There we go. Release. Let's see if it'll, no. Yep, that's got it. Okay, let's go back over here. This is caught behind, let's see. That other suture's caught behind there. There we go. I see, it's crisscrossed there. Okay, let's go here. Grab the tissue. Okay. Release. Okay. We'll try. Okay, we'll reload, go back down, see if it'll come in. Oop, maybe. Do you have the suture? You're welcome. Push. So we're going down without the over tube, we just go slide in. No, when it's closed, it's not an issue. Okay. Let's see. So you can see the.
You had a good work while we were.
Yeah, we have. We've done 4 sutures. We have 2 more to go, and we have to get as much as we can here. We're just going to clean out a little bit of the blood. Sorry, it's a bad time. We're trying to clean up for you before you came back.
We have discussed fatty liver disease and about what will become with this lady if she would stay with her body mass index more than 35. So maybe a treatment for her fatty liver disease would be this procedure.
Yes, I mean, it's true. I mean, basically what we anticipate is the best result at 24 months is about 19% total body weight loss. The average, I would say, is about 15 to 16%. So the range is going to be 12 to 20% total body weight loss for those who have a BMI of about 30 to 40. Above 40, they'll have more weight loss because, of course, they have much more body mass. Okay, we're going to load up again now.
She was perfect, 31.5 body mass index.
31. Yeah, so she's a good candidate. I would say the best are, 30 to 35. But we do 35 to 40 often enough. Okay, we'll just try to load this up again. Let's see if we can get, no. This is our problem with the orientation here. We're going to see, no. Let me pull back a little, see if that helps. No. There we go. Okay, we're ready to go. So we're now going to go back up to the anterior wall. Let's put in the tissue retractor. Thanks. I've got great assistance here. It's Florian, is it? And of course, George, Professor Balan, Dr. Balan. Okay, we're ready to go. Okay, now we have to pick the spot. So the anterior wall, the more proximal you come, I think the more difficult it becomes to get the tissue we want. We can see it's a little difficult to see our marks even at this point, but we're getting proximal. I'm going to look at the line of the other sutures. It's coming across. So we'll take it in here. I think this is okay. Okay, let's go tissue retractor out. Okay, helix in. Okay, that's good. We'll pull this up. Suck. Okay. Okay, release. Okay, we'll try to reload here. Good. Okay, and now let's go back up. There's our first. We'll try to get maybe in around here. Okay. Not yet. Okay, right here. Got that fold, yeah? Okay, we'll pull, oop, just a sec. Go ahead.
Not sure.
Okay, there.
Maybe not.
Yeah, when this tissue starts to spiral, usually you have a good grip. We're going to turn a little bit this way to get a little more. Turn the small wheel towards you. We'll pull up. Okay. Okay, release. Reloading here. Oh. I can see Florian, you watch his head. If his head goes like this, it means it's a good line. If he goes like this, it's a bad line. We just watch you. I think this is going to be the one, maybe. Right here, no? No. Oh. Crazy. Try this way. Yes. Okay. And now come back down. Let's see, that one is there. So let's go in here. Just a sec. Just a sec, George. Okay, go for that. Okay. So that when you get closer up to the fundus, more proximal stomach, more tissue to get through. We're going to turn into it a bit here. Turn a little bit more, push it. There, okay, like that. Okay, release. Okay. Do we have irrigation on the scope?
Avem irigație, avem canal apă, o pompă. Da, yes, we have it.
Okay, we'll take some. That's not helping too much. Okay. And there's that one. We're going to go take it more down here now. Okay, take this. Okay, release. Okay. Go in here. Go ahead. Okay, release. Okay, now I go back over here. Go ahead. Okay, release. Okay, now we go back up top. This is where it's a little more difficult in here. Needle out. Go there. Okay, hold it. Now we're closer to the fundus, and you have you get more full thickness for sure here. And this is also where you get more complications. Okay, release.
It seems 6 were enough.
Yeah, I don't think we would get more.
Yeah.
This is the first row for this one.
This is the second one.
Second row.
Yes.
Oh, yeah, yeah. Oh, right,
This
we
is
went
the
back
middle-
up.
The middle of the second row.
Yes, yes, yes. Okay, needle out. Yeah. Or, okay, go ahead, grab it. Okay. Okay, release. Okay. Okay, and now coming down here, there's there. Let's go in about here. Okay. Okay. That's not. I'm not going back so easily. We'll have to clean it off after this one. And now we want to go. There's our mark there, so we want to get this fold here, maybe. Okay. Go ahead. Hold it. Okay. Okay, that's good. Release. I think that's it for this one. Yeah, now we'll release this. There's our, okay. While we load up the cinch. First, let me do some tightening. Okay, you can load it up. Take this out for a minute, we can get better suction. Thanks, Florian. Yeah, it's good. Yep. Excellent. Okay. Just a second, yeah. There's the suture there. I see it going in there. So I'd like to be close to where the suture goes in. Okay. Okay. Open, yeah. Go ahead. All the way. More. There. Reload. Now, let me wash. So I'm going to come out just to clean up one more time, then the last one. Yeah. Yeah, that's good. Okay. Okay, look at the last up here, and there's the GE junction. So we just bring this one. This is our last. Yeah, okay, it's not bad. 6 is okay. Okay, Florian, great job, man. Thank you. You too, but not as good. No, I'm just joking. Okay. I hope yes. Ooh. Yeah. Oof. Excuse me. Okay. Now, for the last, we have to go up here. Okay, let's go here. You look. Okay. 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 Release. I can't see. I got there. No. I can't see the side so well. Maybe I can. Just take this out so I get better suction for a minute. Okay, just so we know. Ah, close. Okay. Let's reinforce the last one there. Oops. Harder to see, but I think we'll take this fold. We need just a sec. Oh. So it's where the other one was, but it will reinforce it. Go ahead. Okay. Release, yeah. Can't see the... Oh, oh, it's caught. There we go. Okay. Okay. Oh. Okay, release.
We're so close. So
Yeah.
we have the 100 cc up there.
Yeah, no, I think this is it.
Yeah, good.
So we just have a couple more to pull in here.
Yeah.
I think that we won't do a double line for this
Yeah.
one, I don't think. Okay.
This is the posterior line. Yeah?
Yeah, this is the, yeah, but I'm going to take a little more. Okay, we'll go. Go ahead. Okay. Oops. Okay, release. No. Can't see, it's hard to see because of the mucus. I'm not sure if I can wash this, I don't think. Got lucky. Okay, I think we make this our last because I don't think you can see so well. I think it's pretty good. Yeah. I think we'll go down here. Take this. The line is there. Over there.
Prefer to twist it a bit or to twist, yes, the last one.
Not so much. It's only one, it's only going to be one line.
Okay.
I mean, we could go back a little bit. Let's see where the last suture is there. So we'll go in here maybe. Yeah. Okay, go ahead. Okay, all of that. Now we'll come in here like this and bring it up and rotate. Release. Okay. I think we're at the G junction more or less. Let's see. There's the junction, within a centimeter or two. I think that's it. Okay, we're going to release. Thank God. The worst if that doesn't release. Okay, just a sec. Then we'll go back with the regular scope to have a look, to check for bleeding. Okay. Okay.
Dala, pégate.
Okay. Okay, now, before we come up, we have to close the scope. Close the needle before we come up. We're going back with one more scope to look. So just close this. Now we'll go back with the other scope to have a look. Next turn. Not as interesting as the RCP. Huh? I will. We'll show the image of the final production. We'll put this scope in. Yeah. There we go. Yeah. Nice. Yeah. HQ is good.
Yes, yes, yes.
Nice,
The
nice
latest
scope.
version,
Yeah. We have lubricant.
Lubricant.
Gabriel, thank you. Okay. Okay. Very nice, yeah. Yeah. Oh, yeah.
She says she will be next patient.
Yeah, but who's going to assist me? You have to be my assistant. So there's it's pretty good. It's okay. Thank you. Thank you. Yeah. Okay. And there's a little, it's about a centimeter, there's a little bit of fundus left here. Ooh, what's this? Hematoma. That's okay. Thanks. Ah, Mooks. How you doing, man?
What are you looking for after when you're examining post?
After the procedure? Well, looking for any bleeding, you know, even if it's a bleeding, and just to record sort of the residual fundic capacity, just get an idea. It's more for having a sense of going forward whether it makes a difference, you know. But nothing, you know, usually it's brought up within about a centimeter of the GE junction. Usually we have about 150 cc's of fundic capacity. And then, you know, the length. Now, the only thing that some people do, Abu Dhabi and Rochester Mayo, he'll sometimes, if you have extra sutures, he'll go down here, he'll suture from here up to here to here. He'll try to shorten the length of the stomach and reinforce, you know, the other suture line. But I think it's okay. It's fine.
Along the same suture line?
Yeah, along the same. Just here to here to here to here. Pull it in to shorten it. But only not going two lines, just one line, one suture. Okay, we're all done. Yeah. The audience could see this, it's okay. Can we finish?
From the audience, there are some.
Oh, I see. Oh, yeah, so no, 2 months of PPI. And for the first 48 hours, clear fluids only, and then full fluids only for 1 week, and then pureed foods for 2 weeks, and soft diet for 2 weeks. So regular diet, not before 4 weeks. And she has to take ondansetron, 4 milligrams QID, aprepitant, emend, to prevent retching and nausea, because she'll be very nauseated afterwards. And maybe we could give her solumedrol 10 milligrams, because that'll help the inflammation. Okay. And sometimes we give a gram of IV acetaminophen. I don't know if you have that.
Yes, they have it. Yes, they have it. Paracetamol.
Okay. All done. Okay. Thank you. Okay. Great job, man.